Bismillahirrahmanirrahim. Abnormalities of the adrenocortical secretion, specifically the hyperadrenalism, is discussed in this video. There are many causes of hypercortisolism or Cushing syndrome. Uh, it is caused by hypersecretion of adrenal cortex hormone, especially cortisol, leading to a variety of systemic effects. It can result from disorder of pituitary gland, hypothalamus, adrenal gland, or ectopic sources of the adrenocorticotropic hormone. The key causes are anterior pituitary adenoma that results in Cushing's disease, that is most common cause, and it is associated with uh, increased ACTH and cortisol because it causes adrenal hyperplasia that results in excess cortisol secretion, and it is most common cause of Cushing syndrome. Then uh, there is hypothalamic dysfunction. Excessive corticotropin releasing factor is secreted from the hypothalamus that increases ACTH and cortisol secretion. Then there is ectopic ACTH secretion or paraneoplastic syndrome that happens in abdominal carcinoma, and this is usually non-pituitary, and examples along with abdominal carcinoma, other example is a small cell carcinoma of the lung that can secrete adrenocorticotropic hormone, and it results in high ACTH and high cortisol level. Then adrenal cortex adenomas. The primary adrenal tumor secrete excessive cortisol, lead to high cortisol but low ACTH due to negative feedback effect on the pituitary, and accounts for 20 to 25% of the cases. And the Cushing disease is a term that is used for ACTH secreting pituitary adenoma, while Cushing syndrome is a general term for all conditions causing hypercortisolism. Most symptoms are due to excessive cortisol, but excess androgen can also lead to viralization, such as hirsutism or acne. And cortisol causes protein catabolism, hyperglycemia, muscle wasting, and fat redistribution. Sometimes other cause of this hypercortisolism is therapeutically administered cortisol that is used in rheumatoid arthritis and other chronic diseases. Dexamethasone suppress test or dexamethasone test is the first step in the differential diagnosis of the Cushing syndrome. This dexamethasone is a potent synthetic glucocorticoid that mimics cortisol's negative feedback on the hypothalamic pituitary adrenal axis. Normal physiology of the dexamethasone is that this suppresses ACTH release and decreases cortisol production. In Cushing syndrome, this suppression mechanism is disrupted. If ACTH is increased due to ACTH secreting pituitary adenoma, hypothalamic pituitary dysfunction, so there if this is used in low dose, there is no suppression of ACTH, and in very high dose there is suppression of ACTH. So in primary adrenal cortisol overproduction or ACTH independent Cushing syndrome, Here, the ACTH is low or undetectable. Sometimes this test is incorrect because the tumor do not respond, or there is presence of paraneoplastic syndrome that is causing this condition. So the clinical picture of the Cushing syndrome is abnormal fat distribution. There is mobilization of the fat from the lower body, arms and legs become thin. There is fat deposition in the thorax and upper abdominal region, that is central obesity, and there is buffalo hump, fat pad over the upper back and neck. The typical facial changes, that is edematous appearance of the face, that is termed as moon face, a round, puffy and edematous face due to fluid retention and fat deposition. Facial flushing is also common. There are changes in skin and hair. There is oily skin, and there is also hirsutism due to effects of the androgens. There is presence of purple striae or stretch marks on the abdomen, thigh or breast due to protein breakdown and skin thinning. There is hypertension that is present in about 80% of patients, and it is caused by cortisol's mineralocorticoid-like activity leading to sodium and water retention. Cortisol increases the sensitivity of the blood vessel to catecholamines, further raising blood pressure. Other features are muscle wasting and weakness from protein catabolism, osteoporosis due to inhibition of the bone formation, increased susceptibility to infection due to immunosuppressive effects of the cortisol. This picture is showing a woman with Cushing syndrome, and after the subtotal adrenalectomy, the partial surgical removal of the adrenal gland. So on the left side here, the face appears round and puffy. This face is round and puffy, consistent with the moon face characteristic of Cushing syndrome. This is a mild facial swelling and a fuller appearance due to fluid retention and abnormal fat deposition. The skin may appear slightly flushed, and there could be subtle acne or skin changes related to increased androgen. While after surgery or subtotal adrenalectomy, the face is less puffy and appear more angular and natural. There is a reduction in edema and facial fat that is evident due to correction of the excess cortisol level after the adrenalectomy. Overall, the face looks healthier and closer to normal proportions. This change visually demonstrates how treating the underlying cause of the Cushing syndrome can reverse many of the abnormal physical features associated with excess cortisol. So, what are the effects of the Cushing syndrome on carbohydrate and protein metabolism? There is increased gluconeogenesis and decreased glucose utilization that causes increased blood glucose concentration, that is termed as hyperglycemia, and this blood glucose can go up to 200 milligram per deciliter after a meal, and it is caused by both the increased gluconeogenesis, that is increased glucose production in the liver, and decreased glucose utilization by the peripheral tissue due to cortisol-induced insulin resistance. This leads to steroid-induced diabetes mellitus, that is also called as secondary diabetes. Then there are effects on protein metabolism. The protein catabolism is increased, so the tissue protein are decreased. So there is muscle wasting uh, and weakness due to breakdown of the muscle protein, and also There is immune suppression that is caused by reduced protein synthesis in the lymphoid tissue. The patient becomes prone to infection, which is a common cause of death. Then there is loss of collagen in the skin, lead to thinning of the skin, formation of large purplish striae, that is stretch marks due to skin tearing, and osteoporosis due to reduced protein matrix in the bones that lead to bone fragility and fractures. So the high blood sugar, that is risk of diabetes like symptoms, muscle protein loss, weakness and fatigue, and collagen breakdown that is associated with thin fragile skin with easy bruising and purple striae, and bone protein loss that leads to osteoporosis and fractures are the key features of Cushing syndrome. The primary goal in treating the Cushing syndrome is to reduce the excess cortisol, either by removing the source of overproduction or by blocking its effect. So, surgical treatment is one option is adrenal tumor removal. If a single adrenal tumor is there, so it can be removed, and the condition is cured. Then, if there is a pituitary tumor, as happens in Cushing disease, there is transsphenoidal surgery to remove the pituitary adenoma, a preferred method. Then radiation therapy can be used. If the surgery is not successful, then the medical therapy is another option when surgery is not possible, or as a temporary measure before surgery, stridrogenesis inhibitor, uh, meterapon, that inhibits the cortisol synthesis, and ketoconazole that inhibit multiple steps in steroid synthesis can be used. Aminoglutathione inhibits conversion of cholesterol to pregnenolone, that is the rate limiting step in the steroid formation. Then there are drugs that inhibit ACTH secretion, such as serotonin agonist and GABA aminobutyric acid transaminase inhibitor. For example, valproic acid may decrease ACTH release in pituitary-dependent Cushing's. Then adrenalectomy uh, can be used in both the partial or total adrenalectomy is used when other treatment fail. Post-surgery patients require lifelong glucocorticoid and mineral corticoid replacement therapy to prevent Addisonian crisis. Treatment of iatrogenic Cushing's is if it is caused by prolonged use of glucocorticoid medications. There is gradually tapering of the drug that is necessary to avoid adrenal crisis, and it is substituted with non-steroidal therapy if possible. Thank you for watching this video. If you have any query, please write in the comment box.